Well, I'm Dr. Jim Del Rosso from Las Vegas, Nevada, and I'm very happy to be bringing you Spilling the Tea with Dr. D. So normally, this is my teacup, but in honor of the Beatles, right, who in February 1964, not that long ago, came to the United States for the first time, I have a Let It Tea mug. So we always mix it up here at Derm Squared. So I'm actually going to be presenting today based on a presentation that I put together for this 2026 American Academy of Dermatology. I was assigned to do an isotretinoin update. When I first was asked to do that, I was thinking about it, there's little bits of information here and there that seem to trickle in. There's the iPLEDGE update, so you always want to stay current, and you can get that information on the recent iPLEDGE. The dermatologists and the American Academy of Dermatology are always petitioning back and getting some usually favorable changes to the iPLEDGE program for us. So stay up to date on that. That's extremely important. And we have to recognize with isotretinoin that we always have to respect the use of iPLEDGE, and also, depending on how we're using it, to pay attention to all the things we know about it in terms of evaluating the safety of the patients over time. And most patients do extremely well without any major adverse event difficulties. But the other part of it was I was wondering what I was going to include, and I shifted from wondering about that to realizing that there's a lot to talk about with oral isotretinoin. I actually was in my residency in 1983 to 86 when isotretinoin first came out. So I was aware of all the data that supported its release, using it early on, and then being very involved over the years in the area of acne and being right there with the gurus of this particular drug early on, people like Albert Kligman and John Strauss and Jim Layden, and even some of the people that were a little younger, but right in the thick of it, Diane Tipitot, Guy Webster. And I gleaned a lot and did a lot of publications on it and a lot of evaluation. But then moving into the modern times with everything else that has gone on with oral isotretinoin. So it is tea time, and you don't want Jim Del Rosso pouring the tea, or I'll look like that nice lady that is spilling the tea there on the right of your slide. So we'll move on to the next slide. So now we're looking at over 40 years of travel. This is from 1982 to now. It's been a very windy road, and we've known about side effects with oral isotretinoin and the expected nuisance side effects like dry eyes, dry lips, sometimes some myalgias and things of that nature that we typically can work through. And then laboratory monitoring, there has been some changes there. Formulations have gone into some of the differentiation, and we'll get to that. The iPLEDGE program, which we always have to follow for anyone using oral isotretinoin. Here we're going to be talking about acne treatment, but for any use of isotretinoin that you might be prescribing it for, you have to follow the iPLEDGE program. Some lawsuits that came about related to inflammatory bowel disease as a possibility, or depression, suicidal risk, and things of that nature, psychiatric side effects, access, and then looking at some of the newer advances, social media impact, and then always risk tolerance. But the vast majority of people that go on oral isotretinoin that are prescribed when they definitely need it, and it doesn't have to be only nodular cystic acne. There are patients that can have very difficult inflammatory acne with papules and pustules, and even comedones that are resistant to other treatments and very bothersome to them, with a lot of psychosocial impact. Those patients, based on guidelines, not necessarily the package insert, but on guidelines, are definitely candidates for isotretinoin. And there's a backup for that. So it's important for you as a clinician to have that comfort level that that patient needs oral isotretinoin. Next slide, please. So if we want to learn about the future, a lot of times we really have to look at the past. And one of the things that I realized as I was thinking about this topic is that a lot of the information we have, we learned early on. but a lot of it gets forgotten as many of the older clinicians are no longer practicing or maybe no longer around, and we have a lot of new clinicians that isotretinoin is relatively new. They're only looking at newer literature, and they don't have a lot of the foundational information that is really important with oral isotretinoin. So I'm going to go back on that because I was very involved in learning that, evaluating it, and publishing on it, and also doing some clinical studies. Next slide, please. So have we gone full circle? And what I'm going to tell you is in some areas we have, but in some areas we've modernized some, and with good reason. So I'm going to differentiate some of those things. Next slide, please. So this is an article that was some time ago. This was going back to 2012, I believe it was. It was the Journal of Clinical and Aesthetic Dermatology. And it was a very exhaustive supplement that I actually really wrote start to finish, and then worked it through with the other authors that spent a lot of time going through it and making modifications to look at everything we have at that time with regard to oral isotretinoin. And I would recommend, if you're really interested in isotretinoin, getting that article. It's open access on PubMed. You put in Leiden, Baum, Del Rosso, and isotretinoin, you'll find it, and you can print out a copy for yourself. Obviously, it's a while ago, but there's a lot of foundational information that is the core of isotretinoin. And a couple of things we recognized early on was that there were patients that didn't necessarily use the defined course. So the package insert said 16 to 20 weeks of therapy at a prescribed dose. And with isotretinoin, conventional isotretinoin, which was based on Accutane at that time, and conventional isotretinoin still is based on the original, product, the pharmacokinetics of Accutane, right? There were some patients that used longer courses, and even if they did go longer than the 16 to 20 weeks, some of them needed a repeat course of isotretinoin, and it's important to look at that. So if you have a patient that doesn't respond to the initial course and you feel comfortable they've taken the dosages that you're giving them, the vast majority of it, they've completed the course, and they just don't have a good response, or they recur quickly, maybe they didn't get enough, maybe they didn't use it long enough. You have to remember that conventional isotretinoin, that's based on the pharmacokinetics of Accutane. That was patients getting 50 grams of fat with each dose, not just taking it with food, was what was evaluated. So patients may be just taking it with water or not absorbing very much because they're taking what they think is 40 milligrams, but maybe they're only absorbing 20, right? Because they're not absorbing very much because they're not taking it with an adequate amount of fat in the diet. And we only have as comparison the 50 grams of fat or taking it with water. We don't have any data in between. But the bottom line is lack of absorption of the drug can be a significant problem. And we'll get to how the formulations affected that later. Also consider that patients may have other sources leading to their acne. Maybe they're utilizing androgens. They're injecting themselves or taking oral androgens to bulk up, or for some other reason, right? That could be contributing to the acne. Or it's a woman that has polycystic ovarian syndrome, and that's gone undetected. So they may respond to oral isotretinoin, but the disease comes back. Or they have some other type of androgen excess, or as I mentioned, dietary issues where they're not absorbing as much of the drug. So one of the things we learned, and John Strauss did an outstanding article years back, very low doses, and then going up to a variety of different doses. It didn't matter. Even low doses, the patients would clear, and they were taking 16 to 20 weeks. Sometimes they would stop at that point, and they would clear a couple of months even after they were off the drug. They maybe got significantly improved. So we learned that. But the long-term effect of a course of isotretinoin, where they don't relapse, you can essentially get just about anyone on any dose that you're giving, with some exception, but the majority of patients clear by the end of that course, as long as they've taken enough. But keeping them clear is part of the long-term success. So we've come to recognize that, and we also recognize that a cumulative dose, and they came up with the conventional isotretinoins, which are the branded generics that we have now, not the special formulations, was 120 to 150 milligrams total cumulative dose. And to some extent, that's true, but it really is getting enough in, and we'll talk about that a little bit more. If you shortchange that, they're more likely going to relapse. Next slide. So the whole issue about once a day versus twice a day was looked at early on, and I can tell you we like to give isotretinoin once a day, but if the doses are high, and this was data that the FDA used to come up with twice daily as the on-label recommendation for isotretinoin, and they don't distinguish the dose. But these studies were done on high doses. The once daily was 100 milligrams, and then they had a twice daily where they went from 80 milligrams to 40 milligrams. And if the dose gets to a certain extent, you can have a ceiling or an inconsistency in the bioavailability. But typically, if you're going from like 20 to 60 milligrams, it's not as likely to have that. Once a day, 20 to 40 is fine, and 60 milligrams, if the patient's not going to divide it, right, they're not going to be consistent, then the recommendation that I would go by is to give it once a day. Next slide. That's just for the consistency of it. And also, when we look at the adverse events, I'm not going to spend a lot of time on this because it's a presentation in and of itself, but we know that there's a lot of nuisance type side effects, dry eyes, dry skin, things of that nature, which we can supplement with moisturizing, of the skin, and gentle cleansers, and certain over-the-counter ocular preparations to reduce the dry eyes. This article, make note of it. It is open access, goes through all the possible side effects. In case you get something that's rare, you can go to this article and you can see what the literature says about it. But the vast majority of adverse events are reversible and manageable. But teratogenicity, you have to avoid exposure of the fetus to isotretinoin, or teratogenicity is a very significant issue. So you need to follow, no matter how long the patient's on it and how comfortable you get with them, you have to make sure that you're staying on top of pregnancy testing and discussing pregnancy with them at every visit. Next slide. So this was important. This was looking at oral isotretinoin and what are the factors that led to relapse. So one of them that Jim Layden told me years ago, and he turned out to be right based on all the data that I've ever seen, is the earlier they are, like if they're in their early teens or preteens, certainly, but early teens, and they need oral isotretinoin because of the severity of their acne, they're the outliers that are getting very severe acne earlier in life, and they're more likely going to need a second course of oral isotretinoin. So if you have a patient there that you're going to get on oral isotretinoin that's 10, 11, 12, 13 years old, it's important to tell the patient, the parents and the patient, that they may need another course, but we got to get them clear first, and they may not. And you can see the numbers here are broken down. Next slide. The other situation that's important is the formulation is very, very significant. So there was a low-dose isotretinoin that became available under the brand name of Absorica, which does have a generic available now. This is the first of the two special formulations. What's important is it's not necessarily stated that they have to take it with fat. They could take it on an empty stomach or with water because they're substantially more absorbed in the absence of fat when you use that special formulation versus the standard conventional branded generics, which is the majority of what your patients are going to get, unless you're assuring that they're getting at least a low dose formulation, or even better, as we'll get to, the micronized low dose formulation. So that's extremely important. If they're not, and they're just taking the conventional isotretinoins on an empty stomach, they're getting a lot less, even though when you add up the dose, right, you think they're getting a high cumulative dose. I suggest just divide it in half as a general rule. That's actually what they're likely absorbing. So they're not getting the full cumulative amount, and they're more likely going to relapse. Next slide. So this was a study that we did, and unfortunately, we couldn't do the perfect study. This is with the low-dose isotretinoin that was administered without food. So we didn't have all the comparisons to the conventional isotretinoin. We would have loved to have that. We didn't have the low dose with and without food, but we had historic data on relapse rates. I showed you one of the articles that I went through everything that I could find, and so have others, and I've looked at that. And this is to show you if they took the low dose isotretinoin they were patients that definitely needed oral isotretinoin, and they took them for the standard regimen. So they were on for 5 months, and then they stopped it, and they went out to 2 years on nothing. So they could use nothing, not even an over-the-counter product, not a light treatment, not a laser or some kind of spa treatment or a peel or a facial, nothing. This shows you how many patients needed any type of retreatment, an over-the-counter product, a prescription, an oral antibiotic, any type of topical. 8 out of 10 needed no retreatment of their acne after taking that initial course of the low-dose formulation of isotretinoin. Those numbers are historically better than what we have previously seen with other data. So if you look at any over-the-counter, only 6% needed an over-the-counter product. Only 4% needed retreatment with isotretinoin. The conventional rates are anywhere from 8 to over 20% need a second course of isotretinoin. Prescription topical retinoid, 6%, right? 4% an oral antibiotic. Extremely low, even when they needed an additional treatment. And you can see the breakdown on the ages below. Next slide. So now we're looking at what happens when you go to the micronized isotretinoin, right? So this is Absorica LD. That's not available generically. So there is an issue if you look on the right. Very limited access, so it's very hard to get it for patients. If you can get it for them at means that they have access and it's not a financial burden to them, this is the formulation to use. The dose is going to be lower. It's going to be 0.4 milligrams per kilogram and then going to 0.8 instead of 0.5 milligrams per kilogram a day for the first dose, for the first month, and then going up to 1 milligram per kilogram after that. As a general rule, this is 0.4 and 0.8 because they require less. And you can see here that red line. Look at how much more they absorb than the low dose, which was significantly more than the conventional. So this is a very, very important advance if you can get it, because it, without food, without fat, doesn't matter. The patient is going to absorb it. It takes away all that dietary influence. Next slide. So this is the summary of try to get the best formulation if you can. A lot of times you may not. If you can get them a low dose formulation, not necessarily the micronized, even the generic, though we don't have as much knowledge of what's going on with the generics. They're supposed to be as good as the branded version of the Lidose, but also consider if they're taking conventional isotretinoin, if they're just taking it on an empty stomach. I have had several patients failing because of that, having their acne come back quickly, and then working around that, and then them responding because they're going to be absorbing more. Try to obtain once a day, and then optimize the dosing. So the standard dosing with conventional isotretinoin is 0.5 milligram per kilogram per day for the first month, and then the second month is 1 milligram per kilogram per day. And typically they're going to do that. The conventional way is 16 to 20 weeks, maybe longer, as you saw on the previous graph. So you want to get enough in, right? And hopefully they can tolerate that. We'll get to that a little bit later. They may have tolerance issues where you need to adjust it. Next slide. So this is looking at laboratory monitoring. Back in the day, we used to get full serum chemistry panels and CBCs on everyone, and certainly pregnancy tests in women in childbearing potential. That has not changed. You want to make sure of that. But the recommendations according to iPLEDGE I would follow, and even be more stringent if you feel you need to be in a given patient. But the whole idea of getting all the tests every month has changed. So this is a consensus panel, and there's been a lot of articles written on this. There are certain things to get at baseline and then check usually pretty early on during treatment. They talk about peak dose here, but when the patient has transitioned into their cadence into isotretinoin after a month or two, that's when you want to make sure you get your ALT, alanine aminotransferase is what they recommend here. The ALT to look at essentially liver function, looking at their liver profile, triglycerides, and those are really the two main things you need to look at. No more CBCs, and look at all those other tests that have gone by the wayside, unless you're testing something specifically in a given patient. So we relaxed on the laboratory testing, adjusted to what you need in the individual patient. And the ones that we need to be looking at, make sure you're checking them early on, baseline, early on, and some people like to do it at the end to make sure they're okay at checkout. Next slide. Now, this is an important question, and we always hear because of the effect that isotretinoin can have on growth plates in younger children. Is it going to affect the height of my child, right? I have a teenager. I'm concerned about isotretinoin. I heard that they may be shorter. And the data on that has pretty much shown that it usually is not going to be much of an issue. I never like to guarantee anything, but I really like this paper from 2025 from John Barbieri's group, that they went back and looked at 226 patients that were treated with oral isotretinoin from over 1,100 controls. And essentially what they found, these patients were before the age of 15 on isotretinoin or oral antibiotics. So we're talking about the isotretinoin group, that by age 18, they were the same as the ones that did not take oral isotretinoin in terms of their height. So there wasn't any significant difference. However, the speed, it seems to take them longer. The velocity of their growth tends to be slowed down to some degree. So that may be something that you notice. I don't think it's ultra dramatic. You can see here the numbers, but it's something to pay attention to, right? So no significant dosage effects were observed in this. This is a paper worth looking at. Next slide. So have we gone full circle? Well, we have to some degree. So these are my wrap-up slides. Next slide. Oral isotretinoin is very forgiving in getting patients clear. So the question is, because you'll see literature saying some people were using extremely high doses. A lot of people are using that intermediate dose that is recommended in the package insert and in a lot of the standard literature. Some are using lower doses, right? Like 0.25 milligrams per kilogram per day. So what does Yoda tell us? Yoda to me is John Strauss years ago. I had tremendous respect for him. They all work in getting the patients clear. The key is, can I keep them clear? So this was a more recent evaluation, and I really like this because this really went back. When you see John Barbieri and his group, they're going to drill down on a lot of data. And I really typically agree with the vast majority of his conclusions, if not all of them. What they did show was get enough in. Make sure you're getting the patient a good cumulative dose. But the daily dose did not matter. So if you treated at a lower dose longer, right, you would get the same result than if you had a higher dose for a shorter period of time. And where that's important is sometimes the patients can't tolerate that even 1 milligram per kilogram per day. They get aches, they get dry eyes, they get dry lips, they get headaches, and you cut the dose back so you treat longer, respecting that you got to monitor side effects, pregnancy considerations while the patient's on the drug, and always follow iPLEDGE. So that's why I put a gold star next to that. Excuse me. Sorry about that. I am human. Next slide. Right. So when is the course finished? Right. So the defined duration, this is the conventional according to the label and a lot of the more previous literature. You start slow, let's say 0.5 milligram per kilogram per day for a month, and then go up after a month or two to 4 to 8 weeks to 1 milligram per kilogram per day as an average, and then try to get to the cumulative dose. If you're calculating it, it's 120 to 100 milligram per kilogram per day. If you're utilizing the advanced formulations with greater absorption, there's less concern about that because they're going to get it. And then you can adjust that individually based on the needs of the patient. So Tinkerbell says you're all done, but not so fast. We have a modern view, and this is how it's being done now by more people, including some of the originals, like Jim Layden told me not that long ago. This is what he's recommending now, and this is really it. There's not the other one is not necessarily wrong, but this is the way people are thinking about doing it now. Treat until they're clear. And Jerry Tan and some others have written some nice articles on this. Treat until they're clear, and then go a couple of months longer. Now, if they clear within 2 or 3 months, that might be too short. But I'd want to make sure I'm going at least 4 to 5 months, and then beyond that, till they're clear, and then go a little bit beyond that, about 2 months beyond that. That's more definitive because you know they're clear, right? And that's more of the modern way of doing it. So I'm going to stop at this point. I hope this helps you with oral isotretinoin. I've finished my tea, right? I spilled it a little bit, but I'm not going to show you the mess that I made. But you don't want me in a kitchen or a lab. But hopefully you do like hearing me on Spilling the Tea with Dr. D. Thank you very much.